Hello, good evening, everyone. Am I audible and visible? Please give us a thumbs up so that we can start. Good evening, everyone. Welcome to the revision classes. Am I audible and visible? Please give us a thumbs up so that we can start without delay. Okay, so let's start it. So yesterday we did what were the physiological changes occurring in the hematological system, and there we studied that hemodilution has occurred. There is increase in the RBC cells by 20%, but the increase in the plasma of the blood is by 40%. So as a result, there is hello Isra, hello Drinkle. Let's start it. All is good, right? So in the hematological system, we study that there is hemodilution. Why is it so? It is so because the increase in the RBC is only by 20%, and increase in the plasma is by 40%. Therefore, the hemoglobin concentration decreases as a result, and the cutoff value to say a patient as anemic in pregnancy is 11 gram. Okay. Hello Kavita. Hello Surendra. So that was it. So the most important thing which we did was that due to this physiological anemia, that is due to the hemodilution anemia, there is increase in the reticulocyte count as a body response to that hemodilution, and uh, the pregnancy is a hypercoagulable state. I told you quite often it is asked which two factors increase in pregnancy. They were all the clotting factors increase, but two factors decrease during the pregnancy. They were 11 and 13. And as the fibrinogen increase, so it's very normal that in the pregnancy, if we check the ESR, it is high. It is around 50. Okay. So that was it. And as the HB mass increases, similarly total protein concentration also, total protein increases, but protein concentration decreases due to hemo dilution. And in the pregnancy, we studied that globulin protein, it increases is as compared to the albumin, rather albumin decreases. So albumin globulin ratio is uh, reverse. It is 1 is to 1. Normally it is 2 is to 1 or 1.7 is to 1. So in pregnancy it is 1 is to 1. And those who forgets that globulin increases in pregnancy. So in the pregnancy there are golu molu bacche. So that is why globulin increases. Okay. So it's just a mnemonic to learn. So that's it. Then we studied about the cardiovascular changes. I told you that in hematological system that there is increase in the. So here I would like to tell you these are the two physiological changes in the dermat system. Okay, see here in the images. These are the two physiological changes in the dermatological system. This a straight line on the abdomen. This change is known as linea nigra, and this darkened face is known as calosma. Okay, I hope you all these simple things are too asked in exams. Okay, it can be asked. So in the cardiovascular system, as we have studied in the hematological system, that there is increase in the plasma volume. So to accommodate that increased plasma volume, the heart has to pump that increased volume. So as a result, there is increase in the cardiac output, and and you know that formula of the cardiac output is heart rate into stroke volume. So the heart rate also increases and stroke volume also increases. So all the three factors increases. The central venous pressure or the jugular venous pressure remains constant. This is the parameter which we use. If this is increased, then it means that the patient is of heart diseases patient. The peripheral vascular resistance decreases in the pregnancy. Why it is so? Because we have studied that there is increase in plasma volume. So the capacitance vessels, they dilate in response to the progesterone. Under the effect of the progesterone, the capacitance vessels, they dilate and they accommodate the increased blood volume. So this factor leads to the decrease in the peripheral vascular resistance. Okay, and this decrease in the peripheral vascular resistance due to the dilatation of the peripheral capacitance vessels, this leads to decreased systolic blood pressure in the mother, and as a result the mother quite often has syncopal attacks. Okay, now when the pregnancy is full term, due to the increased mass of the fetus, when a mother lies down, the fetus compresses the superior vena cava. As you can see in the diagram, it's already in the diagram, the fetus is compressing the inferior vena cava. So there is decreased venous return and hypotension is there, and this typical change is only in the supine position. It is not in the standing position, and it is not in the sitting position. It is not when the mother is in the lateral position, and this is known as supine hypotension syndrome. When they ask you in the exam, in one of the option they give you superior vena cava syndrome. Many of the students, despite knowing that superior vena cava is in the brain, superior vena cava is in the upper end of the body, they mark it in the anxiety or in the stress. Please be careful. The compression of the inferior vena cava in the supine position at the full term is supine hypotension syndrome. Supine hypotension syndrome. It is not superior vena cava syndrome. Okay. Now, due to the increased cardiac output, there is a slight cardiomegaly in the pregnancy and left axis deviation in ECG. Okay. So these all are yes, Kavita, I will share it. Just after the class, I will share it. Okay. In case I forgot, then please give a reminder at my Telegram channel @DRRANA Dr. Rana. I am writing it here. In case I forgot, then please give a reminder here at @DRRANA. Okay. The PDF is ready. I will share it. Okay. So so I told you that there is increase in the plasma volume in the body, and heart pumps a lot. So there is a cardiomegaly and there is left axis deviation in ECG. These all are the normal finding, right? These all are the normal finding. The apex gets shifted laterally. Okay, these are the three normal finding. What about the heart sounds? So I have always learned the heart sound in this order. S1 is loud, S2 is normal, and S3 is heard. Let's go into bit detail why S1 is loud. Because S1 is something related with systolic. So due to the increased blood volume, S1 is loud, S2 is normal, and S3 is heard. The reason of all these three is increased cardiac output. S1 is loud. So if you also want to learn in this order. S1 loud, S2 normal, S3 heard. Okay. Systolic murmur and continuous murmur are also there due to the increased cardiac output, because there is increase in the plasma volume. So all the systolic parameters are increased, and that is very very normal. Okay, S1 loud, S2 normal, S3 heard, systolic murmur, continuous murmur. Okay, so all these parameters, they are normal. Systolic parameters are normal. Let's learn about respiratory system. That was all about the cardiovascular system, right? Now let's learn about respiratory system. So respiratory changes are very complex. This we have to learn only by mnemonic. The mnemonic for the respiratory system, the parameters which increase are, first we are focusing on the parameters which increase. The mnemonic is ICTV MOVE. Okay, the mnemonic is ICTV MOVE. Okay, IC stands for inspiratory capacity, TV stands for tidal volume, and MV stands for minute volume. Okay, IRV is constant. What is IRV? IRV is constant. I stands for inspiratory reserve volume, and R stands for respiratory rate, and V stands for vital capacity. Okay, V stands for vital capacity. The reason behind why such all changes are there is that the progesterone stimulates the respiratory center, and as a result there is respiratory alkalosis. There is the patients take deep breathing and there is increased washout. Okay, respiratory alkalosis in a patient of there is respiratory alkalosis in a patient of a pregnant patient. Okay, so as a result, the progesterone has stimulated the respiratory centers such that there is increased carbon dioxide washout, right? And it leads to respiratory alkalosis, because carbon dioxide will be washed out. So in the body there will be respiratory alkalosis. So I always remember the fact that there is carbon dioxide washout, but I never remember in exam that whether there is respiratory alkalosis or metabolic alkalosis. So it gets confused in the exam because we are not familiar with all these terms, alkal or respiratory alkalosis. These are something we learn as intensivist. Okay, so the mnemonic for this is raste mein alka hai. Okay, on the way is alka. The way is on the way is told in Hindi as raste mein. On the way is raste mein alka hai. After this mnemonic I never forgot. Okay, now let us see the changes in the renal system. The changes in the renal system is increase in the glomerular filtration rate. Why there is increase in the GFR in the pregnancy? Because in the pregnancy the body, female body, get increased blood flow due to the increase in the plasma volume. So GFR also increases. Okay, GFR increases. Question is asked on each and every line. If they would have not been PYQ, I have not written any line on the slide. Okay, on each and every word there is a PYQ. That is why I am writing it here. It can be that it is not 5 year, it can be in the last 10 year, but it is a PYQ and it is expected in your exam. Okay, so in the renal system, what are the physiological changes? That there is increase in the glomerular filtration rate. As a result, the increased clearance is there. Okay, serum urea, serum creatinine, serum uric acid, they are cleared more due to the increase in the glomerular filtration rate. So their value decreases. Okay, so their value decreases, whereas urinary urea, creatinine and uric acid values increases. There is only slight increase and slight decrease in the blood values. Okay, so the values of urea, creatinine and uric acid, it decreases in the blood due to their increased clearance, due to the increase in the glomerular filtration rate, and their values in the urine, it increases. I hope it is clear to you. Now let's see the different types of the placenta. Okay, the first type is the placenta succinturata. Okay, first type is placenta. Drinkle, you are asking that will there be quiz on this topic? Already the quiz have been completed on ops. Okay, but revision on the ops will be after 28th. Okay, after 28th there will be revisions. Okay, okay, if you want then you can message me on my telegram. Already the quiz are prepared, you can get it. Okay, you can get the quiz on basic obstetrics, they are ready. Okay, we can do it. Succinturata. So let's study placenta succinturata. Placenta succinturata. So what is placenta succinturata? There is accessory lobe in the other than the main placenta. There is a accessory lobe. Okay, see, this is the main placenta. That the images are in the next. Here you can see that other than the this main lobe, one more lobe is there, accessory lobe, and these two lobes, they are connected by the blood vessels. So this is known as placenta succinturata. A part has got remained in the a part has been left in one more part is there, and their connection is by blood vessels. Okay, is it okay? Now that is known as placenta succinturata. Okay, and accessory lobe is there. Accessory lobe other than one main placenta, accessory lobe is there, and it is connected by the blood vessels. Okay, and it what problem do we get by placenta succinturata? That is the question which they ask you. Okay, there it leads to secondary pph, because when we take out the placenta, the main placenta came out, and the accessory lobe, the extra part lobe which was there, it get left inside the uterus, and it is responsible for secondary pph and sepsis. It is responsible for secondary pph and sepsis. Okay, then it leads to pph or secondary pph sepsis. Okay, right. So now another type of placenta is membranous placenta. This is the membranous placenta. What is membranous placenta? You all know that umbilical cord is made up of three vessels and Wharton jelly enveloped around them. Okay, the umbilical cord is made up of three vessels and Wharton jelly wrapped around it. Now, what if this Wharton jelly ends up beforehand? What if this Wharton jelly ends up uh, before inserting at the placenta? Then the vessels will separate right before their insertion, right? So that is what it is, the membranous or filamentous placenta. Okay, so Wharton jelly ends before the placenta inserts. Yes, Dr. Kavita, it is two arteries and one vein. Left vein is left. That is the mnemonic to learn. You are right. It in the umbilical cord there are three vessels, two arteries and one vein. For the how to remember which vein is left and which vein is left, it is two. Left vein is left and right one gets obliterated. Left vein is left and right one gets obliterated. Just a minute, give me 1 minute. Okay, so that's it here. So what is it? The membranous placenta. In the membranous placenta, the here I would like to tell you that we were discussing that umbilical cord has three vessels. If instead of two arteries, one artery is present, though it is a very rare rare situation, but presence of one artery indicates that that there are very high chances of congenital anomalies. Okay, if on the ultrasound we come to know that only one artery is there, single umbilical artery is written on the ultrasound of a fetal well-being of the female, then it means that this condition is nothing but the fetus has a high chances of congenital anomaly, and it is very rare. It is seen only in the 1% situation. Okay. Okay, now we were discussing about the membranous placenta. In the membranous placenta, I was telling you that because the Wharton jelly ends up before in the cord inserts into the placenta, so the vessels they separate. Okay, as you can see here, this these vessels they have been separated, right, beforehand, and they then get insert into the membrane. Okay, they then get insert into the membrane. Okay, so these are the situations which are and what is the complication of this? The complication of this is vasa previa. Okay, complication of this is vasa previa. What is vasa previa? That in placenta previa we studied that the placenta was in the lower segment, then we said that it is placenta previa. What is vasa previa? When vessels, the umbilical cord vessels are in the lower segment, then it is vasa previa. Okay, because here Wharton jelly has end up beforehand and vessels can be there if in the lower segment, then that situation is vasa previa. Ma'am, is membranous placenta velamentous? Yes, they both are one and the same thing. Okay, they both are one and the same thing. Okay, so what is vasa previa? Vasa previa is when vessels are in the lower segment, and this situation is seen in the membranous or velamentous placenta. Okay, what is battledore placenta? Usually the umbilical cord is inserted in the center, but if the umbilical cord is inserted at the margin, then it is battledore placenta. As you can see here, this is the battledore placenta. Okay, here the umbilical cord is inserted here in the uh, on the margin rather than getting insert in the center. Ideally it should have been inserted here in the center, but rather than inserted in the center, it has been inserted in the margin, so it is the battledore placenta. Okay, next is the circumvallate placenta. What is circumvallate placenta? As we studied yesterday in the placenta anatomy, that the side which is toward the fetus is known as chorionic plate or fetal plate, and the side which is toward the uterus is known as the decidual plate or basal plate. Usually both the decidual plate, see, if this is placenta, here is umbilical cord inserted. So this site where umbilical cord is inserted is chorionic plate, and the site where the which is toward the uterus, the other side is the maternal plate. Usually both the chorionic plate and the maternal plate, they are one and the same thing. Okay, they are one and the same thing. They are one and same magnitude. Okay, but what if the chorionic plate is of smaller size? Okay, but what if the chorionic plate is of smaller size? Say chorionic plate end up like this and basal plate is up till here. Okay, then here the in this margin where there is no chorionic plate, here the basal plate will and the amnion chorion membrane will get together, and it will lead to deposition of the fibrin. Okay, and it will lead to deposition of the fibrin, which will cause APH and IUGR, because there is less chorionic the chorionic plate is less, so there will be decreased transfusion in the placenta, decreased exchange of nutrients, that will lead to IUGR and APH due to the obstructing fibrin deposition. So in this diagram you can see here, this is the chorionic plate. Okay, and it is only up till this, right? And this is the extra maternal plate which has been folded. Okay, so if in the placenta diagram you see a ring like this, then it means that it is nothing but, if you see a ring like this, it means that it is nothing but circumvallate placenta, and its complication are APH and IUGR. Okay. Now a small note on beta HCG. Okay, what is beta HCG? Beta HCG is a hormone which is secreted by the placenta. Beta HCG is a hormone which is secreted by the placenta. In the placenta there are two types of trophoblastic cells. One is the cytotrophoblast and the another is the syncytiotrophoblast. The cytotrophoblast, it synthesizes the villi, and the syncytiotrophoblast is the hormone factory. Okay, so it synthesizes the hormones, each and every hormone, whether it is HCG or whether it is HPL. How to differentiate? Isra is asking how to differentiate between succenturate and bilobate and bipartite. See, succenturate is what it is expected in your exam, and I told you that both will be connected by blood vessels, whereas in bilobate they will not be connected by blood vessels, and bipartite is something that both they are not connected by blood vessels, but both the dimensions of both the lobes will be of equal size. Is it clear? Is it clear? Accessory lobe is present in all these three, succenturate, bilobate and bipartite. Okay, but if they are connected by the blood vessels, then it is placenta succenturata. If they are not connected by the blood vessels, the two lobes are not connected by the blood vessels, it is bilobate. And if the size of both the lobes are of same, then it is bipartite. Is it clear? But do focus on succenturata. Okay, succenturata is what is expected in your exam. Okay, so we were discussing about HCG. HCG is secreted by syncytiotrophoblasts, and syncytiotrophoblasts is the hormone factory of the placenta. Whatever hormone they ask you is secreted by what, you are going to answer their syncytiotrophoblasts. HCG has alpha and beta subunit. Is it clear, Isra? Please write down in the chat box if it is clear to you. Okay, HCG is secreted by the syncytiotrophoblasts, and HCG has two units, alpha unit and beta subunit. A lot of questions have been asked on HCG. Okay, you have to learn it, each and every word. Okay, HCG has two units, alpha unit and beta subunit. Alpha subunit, it is similar to the alpha subunit of FSH, LH and TSH. Okay, so the structure of HCG alpha subunit is similar to the alpha subunit of FSH, LH and TSH. Okay, and its action, the action of beta HCG is only similar, I have written only similar to LH. Okay, so it has been asked three times in the exam that HCG is structurally and functionally similar to, and options were FSH, LH, TSH, H and HPL. So the answer was LH. Okay, because the HCG action and structure is similar to LH, therefore HCG has luteotropic effect. Okay, luteotropic effect, these are noted in three different conditions. First is, it maintains the corpus luteum. Usually the corpus luteum life is only 10 days, but if all these points are written here in the side box, okay, usually the corpus luteum life is 10 days, but if the pregnant if the lady conceives, then this corpus luteum life is not 10 days, it is 10 weeks. Okay, days becomes weeks. Okay, its life is 10 weeks. How? Corpus luteum does not expire, does not disintegrate in 10 days, because when a lady conceives, the syncytiotrophoblasts synthesizes HCG, and this HCG has same function as that of LH, and this HCG maintains the corpus luteum. Here comes the another question: who maintains the corpus luteum of pregnancy? And there they give you option HCG, LH. So the answer is HCG, due to its luteotropic action. The other effect of the luteotropic action of HCG is that when the female is pregnant, okay, and if in the if that female has male fetus, okay, then you all know that testes are differentiated around 6 to 8 weeks, right? And 6 to 8 weeks the testes are differentiated. Now these tests, the Sertoli cell of the testes is have to synthesize AMH, and the uh, Leydig cell have to synthesize testosterone. Now, who gives the stimulus of the male fetus Leydig cell to make testosterone? In the late pregnancy, the stimulus is given by LH, but in the starting, no LH is being synthesized in the male fetus. This stimulus is given by the HCG. Okay, its stimulus is given by the HCG. This one is the last NEET PG 22 question. Who gives the stimulus of the male fetus to the female fetus in early pregnancy to synthesize testosterone? The answer is HCG. Okay, answer is HCG. Dr. Kavita, LH is not synthesized in early pregnancy. Okay, HCG is synthesized due to its luteotropic effect. the testes Leydig cells, they synthesize testosterone. Is it clear, Dr. Kavita? Okay. The third effect of the HCG as its luteotropic effect is in the molar pregnancy. In the molar pregnancy, you all know that lot of HCG is formed. Now this HCG has a luteotropic action. So in the ovaries, theca lutein cysts are formed. In the ovaries, the theca lutein cysts are formed. Okay. Third effect is theca lutein cysts are formed. And when we evacuate that molar pregnancy, then this theca lutein cysts spontaneously they disappear. That is when HCG levels goes down, then this theca lutein cysts itself disappear. Okay, so these are the three luteotropic action of HCG. They have been asked here and there. Okay, I think on at least on this slide of HCG there are 10 questions. Okay, and this luteotropic, out of this luteotropic effect there are 7-8 questions. So please remember these three luteotropic actions of HCG. Okay, now this was it. And this another important thing is that the HCG biochemical nature is glycoprotein. Okay, HCG biochemical nature is glycoprotein and it has the maximum carbohydrate content. That is why it is known as the sweetest hormone, because it has the maximum carbohydrate content. Okay, HCG is glycoprotein. Okay, so they also asked about two hormones chemical nature. One they ask about HCG and the another they ask about AMH. Okay, they both are glycoprotein. Okay, they both are glycoprotein. Beta HCG is also glycoprotein and AMH is also glycoprotein. In the options they write down lipoprotein. Okay, in the options they write down lipoprotein, but these are not lipoprotein, these are glycoproteins. Okay, so write down in the chat box which two hormones are glycoproteins, whichever examiners ask in exam. Okay, all those who are watching this video, please write down in the chat box. It can cost you one answer. Okay, now this beta HCG, when a lady gets pregnant after fertilization, it is detectable on the 8th day. Okay, it is detectable on the 8th day after fertilization. Okay, it is detectable on the 8th day after fertilization. Okay, and the best method to diagnose it is by radioimmune assay, but the routine method it is which is usually done is routine method by which we usually diagnose the pregnancy, urine pregnancy test is, yes, very good Dr. Kavita, very good Dr. Drinkle, it is HCG and AMH. Okay, very good. So radioimmune assay is the best method, but the routine method by which we are diagnosing UPT test, urine pregnancy test, or the blood pregnancy test which we are doing is, it is the ELISA method. Okay, and the best method is yes. So this was about the HCG. Lot of questions asked. Let's study about the other hormones. Placenta synthesizes estrogen. Then the placental estrogen is known as estriol. Placenta also synthesizes progesterone. Placenta also synthesizes HPL, human placental lactogen, and relaxin. These are the other hormones which placenta is synthesizing. Okay. Now let us discuss about the amniotic fluid index. It's a very small slide. On this slide itself, your 9-10 questions will get covered, which have been asked about the amniotic fluid in the past. First of all, always remember that amniotic fluid, its source after 20 weeks is nothing but fetal urine. Okay, amniotic fluid is nothing but fetal urine. Okay, is it okay? And it is maximum at 38 to 34 weeks. As the pregnancy advances, amniotic fluid increase in amount, and at 32 to 34 weeks it is maximum. Quite often students ask that, ma'am, if 32 and 34 both are given, then you have to mark 32. Okay, then you have to mark 32. Okay, and what is the amount of amniotic fluid? It is more than 1 liter. Okay, now because amniotic fluid is nothing but fetal urine, if this fetal urine will not be formed in congenital renal anomalies, then the patient will have oligohydramnios. Okay, on this small fact, questions have been asked, I think 4 or 5 times, that the patient at 22 weeks, the patient had oligohydramnios. What is the diagnosis? The diagnosis is renal anomalies. Okay, bilateral renal agenesis, like this. Okay, the other reasons for oligohydramnios: placental insufficiency, IUGR, or preeclampsia toxemia. Why? In placental insufficiency, IUGR, or preeclampsia toxemia, there is oligohydramnios. This is so because whenever there is decreased blood in the body of a human being, then the blood to the brain and blood to the heart preferentially increases, and to the other body it decreases, because the blood to the kidney decreases, so there is decreased urine production. Okay, so in placental insufficiency, IUGR, and preeclampsia toxemia, there is decreased urine production because the blood flow preferentially increases to the heart and brain. Okay, the other reason is PROM, premature rupture of membrane, or post-datism, post maturity. Okay, now this fetal urine, which was the source of amniotic fluid, the main source of amniotic fluid, it is not that once the fetus does the urine and this is will remain here. Fetus also swallows that amniotic fluid, and this circulation keeps on going. Fetus does the urine and it forms the part of the amniotic fluid, and then fetus swallows that amniotic fluid, and the again that fetus produces urine. All this occur. So if the fetus has GIT anomalies, or you can say swallowing anomalies, then the fetus will not be able to swallow that fluid, resulting into the polyhydramnios. So which anomalies? Write down in the chat box which anomalies lead to the polyhydramnios. Polyhydramnios is due to the GIT anomalies, and oligohydramnios is due to the renal anomalies. Okay, write down in the chat box which anomaly leads to polyhydramnios and which anomalies lead to oligohydramnios. The other anomalies, in the GIT anomalies, the most common is cleft palate. Okay, now the other anomalies which lead to the yes, Dr. Kavita, you are right. The other anomalies which lead to the polyhydramnios is neural tube defects. Because of the neural tube defects, the brain swallowing center gets affected, and as a result there is polyhydramnios. Okay, okay, yes, Isra, you are right. Yes, you are right. Okay, and in the diabetes, due to hyperglycemia, there is polyhydramnios. In RH incompatibility due to the hydrops, there is polyhydramnios. And in the twins, due to the excess urine production, there is polyhydramnios. Okay. Okay. Okay, so that is very simple. You have to just to focus on git anomalies and ntd. The other reasons you already remember, and they are quite less asked. Now let us see the color of the amniotic fluid. And I we studied that at 32 to 34 weeks the amniotic fluid is maximum, and its color is transparent just like water. Okay, so in premature, that is around 32 to 34 weeks, the color of the amniotic fluid is transparent or water like. And after that it starts concentrating, or you can say it starts slight decreasing. Thereafter the color of the amniotic fluid at the term, it is very important, at the term the color of the amniotic fluid is slight yellowish. Okay, yes, sprinkle, it is 1 liter at 32 to 34 weeks, 1 liter plus. Okay, at term, the color of the amniotic fluid is not now water like clear color, it becomes pale, light yellowish in color, to what we say it's straw color. Okay, once in NEET PG they have asked what is the color of the amniotic fluid at term, and there they give two options, milky or pale. ठीक है, so it is not milky, the color gets not milky, the color gets slight yellowish in color. Okay, post, yes, Dr. Kavita, you are right. Post datism, post dated, the color is amber colored. Okay, post dated, in post dated pregnancy the color gets amber colored. Okay, then next is green, green color or meconium stain. Green color amniotic fluid is seen in meconium stain liquor. And in RH incompatibility, the color of the amniotic fluid becomes yellow color or golden color. Why is it so? Because in RH incompatibility there is hemolytic anemia. Okay, the ntd and the ntd antibodies, they do hemolysis in the fetus, and as a result the fetus gets jaundice. And you all know in jaundice icterus is found and urine becomes yellow in color. Okay, so golden color or yellow color amniotic fluid is found in RH incompatibility. Okay, and maroon or red color amniotic fluid is found in abruption, and dark brown colored amniotic fluid is found in IUD. Okay, you just focus on green color at term color and golden color, that are sufficient. Now let us study some small topics. Question do come from basic. Yes, Dr. Isra, you are right. High bilirubin makes the color yellow. Let us focus on small topics. Calorie requirements. Okay, calorie requirements are different in different women. Those who are working very light or those who have sedentary lifestyle, the normal calorie requirement, not in the pregnant, normal calorie requirement is 1800 in them. Okay, in the moderate workers, the people like us who work but they don't work, but they don't do heavy works, in them the calorie requirement is 2100 kilocalories per day. And in the labor class, the one who do heavy work is the 2700. Okay, is 2700. So here I would like to tell you how to remember this non-pregnant female calorie requirement. This is just a table of 3. Okay, 3 6 the 18, then 3 7s are 21. And as you know, labor class works really very hard, very hard. So there we have to go for 3 9s are, not 3 8s are, 3 9s are. Okay, 3 6 the 18 for the sedentary workers, working female, 3 not sedentary working, they are not working, they have sedentary lifestyle. Okay, 3 6 the 1800, then 3 sevens the 2100 for a moderate people like us. Okay, and for the labor class it is 3 nines are 2700. Okay, and for the pregnancy you have to add 350 kilocalories for the single pregnancy. Okay, in Williams the data are a bit different. This was all about the Indian values, and usually you will be asked question on Indian values, but sometimes they ask about the Williams also. So as per Williams had add on all this light work, moderate work, severe work. William has added plus 200 200. Okay, plus 200 plus 200 in each, and 0 calorie requirement in the first trimester, and 300 in the second, and 450 in the third. Okay, so there's a slight variation, not much. Okay, but usually the questions which are asked till date, they were on the Indian requirements, Indian diet charts. Okay. In lactation, because the baby gets feed from the mother itself till 6 months, the baby is on exclusive feed on the mother lactation. So in lactation you have to add 600 kilocalories for the first 6 months, and after 6 months you have to add 520 kilocalories. Okay, the requirement of the iron in the per day requirement of iron in the pregnancy is 40, and the calcium is 1000. Okay, in the lactation it becomes 30, and calcium it remains same 1000. Okay, the tablets of iron which we give is, they contain 60 mg and 500 mg. Okay, on the fact that we take some amount by diet also. Okay, and iron is high in amount as per required, because we cannot give iron in the first trimester. Okay, so we can give iron only in second and third trimester. So iron is almost double the amount. Okay, and calcium is, we take a large amount of calcium in our diet, that is why. Now let us study about the, let us study about the GPL system, how to calculate the gravida para life status. Okay, so G means number of times the lady has become pregnant. Okay, number of time the lady has become pregnant, that is gravida. Okay, and if you don't if you get confused between twins pregnancy and all this, so you have to remember the number of times the UPT becomes positive, number of time the UPT has come positive. So for twins pregnancy only one gravida is calculated, and for the abortion the gravida is also calculated. Okay, so number of time the lady has UPT has come positive. Okay, okay, now para is number of times the lady has delivered the delivered more than 28 weeks, that is parity. Okay, so if you again get confused in this, so here you have to remember by that simple trick. This was given to us by our teachers, and we never calculated in our life wrong formula. Okay, number of times the lady entered the delivery room and delivered more than 28 weeks. What is para? Para is number of time the lady has entered the delivery room or labor room, you can say, and delivered more than 28 weeks. As you know, if the lady is having twins in its uterus, then the lady has to enter only one time. Okay, and the lady, so parity in the case of twins is again in once even if the patient has twins pregnancy. Okay, what is L? L is number of live births, number of live fetus the female has, number of live fetuses the female has delivered. Now here, if the female is has delivered two live sorry twins, then it will be calculated as L2. Okay, then it will be calculated as L2. So gravida is number of times the UPT has come positive. Para is number of time the lady has entered the delivery room and delivered more than 28 weeks fetus. And okay, and live is number of live fetuses the lady has delivered. Okay, so Leopold grips, now we are coming to the Leopold grips. Leopold has given us 4 grips, abdominal grips. First grip is fundus. In the first 3 grip, Leopard first, second and third grip, in the first 3 grips we face toward the, if the patient is sitting, if the patient is lying down, our face is toward the patient face. Okay, so we are looking toward the patient face. Okay, so Leopold first grip is the fundal grip. We put our both hands at the fundus and we try to appreciate that whether it is breech or whether it is twins. Sorry, whether it is breech or whether it is cephalic. In the case of breech, a large round structure is felt, and whereas if breech is there at the fundus, okay, and if there is cephalic part is there at the fundus, then a small hard globular structure will be felt. Okay, leopard first, in the leopard first, second and third grip, the doctor face is toward the patient face, and at first sight we put our both hands on the fundus and we appreciate what we are feeling. Okay, in the Leopold second grip is the lateral grip. What we do there, we put our one hand on the lateral side, we stabilize the uterus by that hand, and with the other hand we move our other hand and feel the parts on the other. Then we stabilize our moving hand, and on the other hand we feel the which part are there. On the one side there is back, and on the other side there are fetal limb. The side on which back is there, it is felt like a curve, more round in structure, and the side where limb are there, irregular type feeling is there, nodular feeling is there. Okay, and in the Leopold third grip we do it by one hand. Leopold third grip is also known as Pollock grip or pelvic first grip. Pollock first grip or pelvic first grip. Here we put our one hand in the pelvis of the female, and in this way we feel with the help of the one hand we feel the after Dr. Kavita, you are asking, ma'am, from which week we can do Leopold? After 28 weeks. Okay, after 28 weeks. So Leopold third grip is nothing but a pelvic first grip or Pollock first grip, and in the Leopold third grip or pelvic first grip or Pollock first grip, we put our hand like this, okay, and we feel the fetus head. Here also our face is toward the mother face. Now in the last grip we change our direction. Now the doctor face is toward the fetus or toward the patient feet. Okay, and now we put our both the hands like this. Okay, and we feel how much is the fetus engaged. Okay, how much is the fetal head engaged. Okay, that is known as the Pollock 2 grip. Okay, so that is why the two hand grip is the pelvic you can learn that in which we are using two hands. It is the pelvic second grip, and here the direction of the doctor changes toward the feet. Okay, when we have to put the two hands, then of course the direction will change. Okay, now a small note, very small note, though we have done this about fetal physiology. This was the last topic about the basic obstetrics. Umbilical cord has two arteries and one vein, and left vein is left, right is obliterated. Single umbilical artery is found only in 1% of the cases, and it is associated with fetal anomalies in 10% of the cases. In 10% of the cases, if there is single umbilical artery, then there is, yes. And umbilical artery, it is very important. Umbilical artery, in spite of it is artery, it carries deoxygenated blood. This question has been asked thrice. Umbilical artery carries deoxygenated blood, and umbilical vein carries oxygenated blood. Okay. Fetal growth, this was the question asked recently in INSET. This is a question asked recently in INSET exams. Okay, that fetal growth is due to which hormones? Except these four options were there: insulin like growth factors, glucocorticoids, growth hormones, thyroxine. So fetal growth is due to all hormones except growth hormone. Okay, so the answer was C. Eraser is actually not going, so I don't know how, why these yellow expressions are there. So fetal growth is due to all hormones except, mainly the fetal growth is due to this. Most important is insulin like growth factor responsible for the fetal growth. Okay, the you know that due to the deficiency of growth hormone, dwarfism is there. But the dwarfism fetuses, they are born perfectly normal, and their growth is hampered after their delivery. Okay, fetal growth is influenced by all except, so the answer is growth hormone. That completes our basic obstetrics. I hope there is no query. If there is query, do write in the chat box so that we can start with our next topic, active management of the third stage of the labor and its complication. This topic is very important, and quite lot of questions are coming on this topic. That is why it has been taken. Please write in the chat box, or write there are no queries in the basic obstetrics so that we can proceed. No, actually, Dr. Kavita, I'm having mild fever. That is why. Don't worry, it will go. Thanks for the concern. Yeah, that highlighter was coming. That's why I take the time. Okay, now let us start with the third stage. Okay, what is uh, third stage? Age the In the third stage there is delivery of the placenta, and in the second stage there is delivery of the fetus, and in the third stage there is delivery of the placenta. As it's very important, so I have started from here. Okay, now you imagine that fetus has delivered and we have to deliver the placenta. The average duration of the fetus is 15 minutes. Okay, average duration of the third stage is, sorry, 15 minutes. What we used to do traditionally is that we used to wait for the spontaneous placenta expulsion. Okay, we used to deliver the fetus, clamp the cord, and we used to wait for spontaneous placenta expulsion. But these now we are doing active management of the third stage labor as guided by WHO. So what is it? This order has been asked in this November 22 INI set exam. Please remember carefully. Okay, first of all, once the fetus has been delivered, we have to look for the second baby. Even if in the ultrasound there is written that there is singleton pregnancy, we have to look for the second baby. Of course, the fundus will be at a very high height if there is a second baby inside. Okay, so we have to give a look for the second baby. Okay, then next is that we will give uterotonics after the delivery of the baby. If there is no second baby, then we will give uterotonics. The uterotonics, which are the drug of choice, these uterotonics are given for the prophylactic to prevent PPH. That is what is the main target of AMTSL. The main target of AMTSL is to prevent PPH, to decrease the incidence of the PPH all over in the world. So here the first thing which we do is we give uterotonics. Okay, we give uterotonics so that the muscles start contracting and there is no PPH. So the dose of the drug of choice for prophylaxis of PPH is oxytocin 10 unit. It can be given IM or IV slow. Okay, and it should not be given IV bolus, as IV bolus will lead to PPH. Okay, as IV bolus leads to hypotension. Okay, this was the question which has been asked in FMG. For the first time it was asked in FMG, though we have been practicing this thing many time in the trainings, we have been told, but in the December 21 this was asked in FMG. So please write down in the chat box. It is a very common mistake done in the hospitals, that IV bolus as oxytocin give hypotension to the patient. Okay, what is the side effect of IV bolus oxytocin? Okay, even when we are inducing labor pains, then also we are giving IV infusion, and even after PPH, the drug of choice is oxytocin. There also we are giving IV infusions. It is not that patient is having PPH and we will give it IV bolus. No, we don't want the hypotension. Okay, the third thing after giving the uterotonic, that is oxytocin 10 unit IM or IV slow or IV infusion, after this we will give the control code traction. Okay, now why there is a control code, why we are giving this control cord traction? To fasten our process of third stage. Okay, the method by which we give control cord traction is Brandt Andrews method. Okay, as you can see here, the this is the Brandt Andrews method of control cord traction. okay, we keep the one hand on the pelvis, and we move it in the forward direction, and with the other hand we give a controlled cord traction so that the placenta gets separate. Okay, so that the placenta gets separate, we give a controlled cord traction. So what in this image can be asked, that what does this image illustrate? This image illustrate Brandrett Andrews method. Okay, Brandrett Andrews method for the separation of the placenta, control cord traction. One hand on the pelvis and other hand giving the traction to the cord. Okay. And after the placenta has been separated, then we have to clamp the cord. Earlier it is advisable that we have to do delay cord clamping, because it allows the blood to go into the fetus and it helps in the recovery of the fetal anemia. Okay, and in the last we have to do uterine massage. So there are 5 steps in the active management of third stage of labor. So you have to remember in this sequence only. That is what was asked in November INSET 22 exam. Okay, look for the second baby, then give uterotonics, then and do control contraction by Brandrett Andrews method, and then clamp the cord by delayed cord clamping, and then uterine massage. Okay, now if we don't have oxytocin, no doubt the drug of choice is oxytocin 10 units. Okay, then what is the other drug of choice? Oxytocin has to be maintained in refrigerators. What if we don't have oxytocin? What if we don't have oxytocin in? Then the other drugs are carbetocin, misoprost and methergin. Okay, carbetocin, misoprost and methergin are the other drugs. Carbetocin is a synthetic oxytocin. Carbetocin, it is written here in the circle. Carbetocin is a synthetic oxytocin. It is given, its dose was asked in the last PYQ exams. Its dose is 100 microgram in 1 minute IM. Okay, and Government of India has approved it only and only for or prophylactic use. We are not using it in PPH cases. Okay, dose of carbetocin is 100 microgram in 1 minute in it IM. Okay, the misoprost dose, which can be used in case the oxytocin is not available, is 600 microgram. Okay, and the methergin, single injection of methergin, that is 200 microgram IM or IV slow. Okay, methergin is contraindicated. Now what does the methergin do? Methergin gives a very forceful uterus contraction. Okay, very forceful, sudden and very forceful uterus contraction. It contracts the myometrium of the uterus, very sudden and very forceful. So suddenly a large amount of the blood from the fetal, after the separation of the placenta, a large amount of the blood comes into the maternal circulation. Okay, and that sudden coming of that blood can be dangerous if the mother is having hypertension. Okay, that will lead to sudden rise in the high BP, and it can be also dangerous if the patient is having heart diseases, because that sudden rise will lead to increase in cardiac output, and in the case of Rh negative, it will lead to the increased transmission of the antibodies. Okay, so I hope you understand this thing, that why methergin is contraindicated in hypertensive mother, heart diseases and Rh negative, and it is also contraindicated if there are one twin is there in the uterus, because then we will not give such a contraction, fetus will get trapped. Okay, now we have studied that controlled cord traction, branded induced method. Okay, there is one another method which is Craday's method. What we do basically in the Craday's method, we squeeze the uterus. Okay, last NEET PG exam it was asked, in one of the option it was there Craday's method, so I have written here so that you don't get confused by seeing that option. It is a obsolete method, it's not practiced. Okay, and what is there in that method, we squeeze the uterus like this. Okay, we squeeze the uterus and we forcefully extract the placenta out of it. So it is obsolete, we are not doing that. Okay, okay, just remember we are only doing branded induced method. Now let us study the sign of placenta separation. Okay, now as you can see here in the diagram that fetus has separated, and once the placenta will get separate, then it will come down, right? It will come down. There will be first sign will be there, because the placenta is supplied by spiral arteries, the branch of the uterine artery, spiral arteries. So the spiral artery will tear, right? Right, on separation of placenta, the spiral artery will tear, and that is why there is gush of blood. Okay, due to the spiral artery tearing, later on the myometrium will contract and there will be stoppage of this bleeding. But once the placenta separates, due to the tearing of the spiral arteries, the arteries supplying the placenta, there will be gush of blood. Okay, the fibers of the myometrium, they are naturally arranged in a crisscross pattern. That is why after their separation there is ligation of this the spiral artery, they get squeezed in between this crisscross arrangement of fibers and then they stop bleeding. Okay, that is why this myometrium is also this crisscross arrangement is also known as living ligature. Okay, this question has been asked that why this crisscross arrangement is known as the living ligature, because after the separation of the placenta, this crisscross arrangement, it squeezes the, or you can say it ligates the spiral artery, the tiered spiral arteries, and bleeding stops. Okay, so now the first sign is gush of blood. The second sign, as the placenta has come down, so there will be suprapubic bulge, bulge, and this bulge will be very round in shape. Okay, and the height of the uterus, due to that placenta has come down here in the suprapubic area, the placenta has come down in the suprapubic area. That is why the height of the uterus will increase. This is known as Schroeder's sign. It is known as Schroeder's signs. Okay, Schroeder's signs. And because the placenta has come down, there is lengthening of the cord, permanent and lengthening of the cord, and this is known as Kushner's sign, and this is the best sign. Okay, this is the best sign. So this was about the signs of placenta separations. These days lot of questions are coming on basic question. First sign is gush of blood due to the spiral artery tearing. Second sign is suprapubic bulge, or you can say height of uterus increases because placenta has come downward. And the third sign is permanent lengthening of the umbilical cord. That is Kushner's sign, and that is the best sign out of this all. Okay, next is, what if this placenta not come out or not separates? Okay, the placenta which does not separate or partially separate is known as retained placenta. the placenta which does not separates, or which does not impartially separates, that placenta is known as retained placenta. Even after 30 minutes of controlled cord traction, even after 30 minutes of the controlled cord tractions, if the placenta is not getting separate, then that is known as the retained placenta. Now, how you will diagnose those retained placenta? The signs of placenta separation will not come. Gush of blood, height of the uterus increasing, the permanent lengthening of the cord, they will not be seen. And this was the question in the NEET PG. Okay, placenta was not separated and the umbilical cord teared. What we do if the placenta does not separate, then it is quite obvious we give more traction, bit more traction, and due to that increased contraction, the umbilical cord it tears. Okay, now if the placenta is not coming out after 30 minutes, then what is the treatment of it? Then we will do manual removal of the placenta and oxytocin. Okay, even after 30 minutes of the placenta separation, if there is no separation of the you can say placenta, and or there is partial separation, and there are no signs of placenta separation, then it's that was asked in the NEET PG. What is the next management? Next management is MRP. MRP means manual removal of the placenta by the manual removal of placenta. Okay, the another etiology is trap placenta. What is trap placenta and how it differentiate from the retained placenta? What is trap placenta? Trap placenta is that placenta has separated, but it is not coming out of the cervix, not coming in the vagina. Okay, here the signs of placenta separations will be present. Here the sign of placenta separations will be present. Okay, here the treatment is same, manual removal of placenta and oxytocin. Okay, we have to take out that removed placenta. So these are two different problems. If the placenta has not come out in the vagina, then even after the controlled cord traction, number one is retained, that is placenta has not separated. If it has separated but not coming out, then it is trapped. The treatment of both is manual removal of placenta. It's quite simple. All these things you are going to do in the first year or internship. Very first day in the ops gynae duties you will do it. Okay, you just these all are the things on which questions are asked. These all are the things which are quite often asked to you. Okay, now let us see the adherent placenta. Okay, placenta, here the nitabush layer, the layer which is below the deciduum basalis, the layer of fibrinoid degeneration, this is it is absent. Okay, so how you will diagnose adherent placenta? That the placenta is not separating even after manual removal placenta attempt. Okay, even after you are trying to separate the placenta manually, then also the placenta is not separating. Usually what happens that when we get the ultrasound done antenatally, there the diagnosis is made, but sometimes they can ask you even after manual removal of placenta, even if then the placenta does not get separate, it means it is placenta is adherence. There below the deciduum basalis there is a small layer of fibrinoid degeneration. Okay, the degeneration layer, and that is known as nitabush layer. And if that due to that placenta separates very easily, but if that is absent, then now the villi they will directly adhere to myometrium. Okay, if the villi they are adhering superficially to the myometrium, then it is known as accreta. If they are going deep inside the myometrium, it is increta. And if they are going up till serosa, then it is percarita. Okay. The investigation, which investigations are done to diagnose adherent placenta, this has been asked recently in the November 21 PYQ. So ultrasound and MRI both can be done. Most commonly done is ultrasound and the best is MRI. Okay. So what is the treatment of it? Its treatment is hysterectomy. We cannot remove this placenta. There are 2 or 3 more treatments, but at your level you have to learn that its treatment is hysterectomy. Okay. And what are the risk factors which prones a patient to placenta, adherent placenta? The risk factors are previous uterus surgery. If there is any scar on the uterus, it is a possibility that the Nitabutch layer have been removed during that uterus surgery, and uterus surgery or uterus scar, and that is why there is a placenta accreta formation is there. Okay, is it clear to all of you? Is it clear to all of you? Now we have done that, we have given the uterotonics, right? Which all uterotonics we will give, I have told you. Okay. And then we studied that we give a control cord traction. If on control cord traction, normally we do it by branded induce method. Yes, Dr. Kavita, you are right. Previous uterus surgery is a risk factor. Okay, so we have done the retained placenta, trap placenta, and adherent placenta. Okay, now we have to, placenta is removed, it is come, and we clamp the cord. Okay, usually we do early cord clamping. Okay, early cord clamping, we do delayed cord clamping, but in some situations we do early cord clamping. Okay, because it is Dr. Isra is asking, is the Nitabutch layer a part of myometrium? It is between the endometrium, or you can say decidua, and myometrium. It is basically a layer of fibrinoid degeneration. It is in between. Okay. So that is why I told you that accreta is to superficial myometrium, right? The villi, they are attached to superficial myometrium. If they are going deep inside the myometrium, it is increta. Is it clear, Dr. Isra? Usually we do delayed cord clamping, but because when we do delayed cord clamping, then the time to take the baby to the resuscitation, because when we are not clamping the cord, it means that the baby is near to the mother, right? And we are not taking that not taking the baby to the resuscitation unit, right? So if the baby needs resuscitation, then we are going to do early cord clamping. Early cord clamping is obvious, is done in the asphyxiated child. Okay, asphyxiated child. Or if the now what happens when we do delayed cord clamping, then lot of blood goes to the fetus. Now if the fetus has heart diseases, and if lot of blood will go to the fetus, then there will be increase in the cardiac output of the fetus. So it will be a problem if the fetus has heart diseases. Okay, so in the case of asphyxia and heart diseases, an Rh negative mother, again lot of antibodies will go into the fetus. So in these 3 conditions, we are not going to do delayed cord clamping, and we will do early cord clamping. Okay, we will do early cord clamping and early cord clamping is also done in HIV positive mother. Okay, HIV positive mother, because more and more virus from the mother to the fetus will get transmitted. Okay, more and more virus from the mother to the fetus will transmitted. Okay, now what they are doing in the in the NCQs, they are writing all these four options, that early cord clamping is done in all except. So as you know, this asphyxia, heart diseases, then RH negative, they are more emergency situation than HIV positive. So you are going to mark their HIV positive. Okay, so once in the NEET exam, they have asked early cord clamping is done in all except, and these were the four options. Okay, so because asphyxia, heart disease of the child, and RH negative are more emergency situations, so there you have to mark HIV positive. Okay, because virus transmission can again be prevented by nevirapine. Okay, so last step in the active management of third stage of labor is uterine massage. Once we have done the clamping, we have removed the placenta, then we massage the uterus. Okay, and we keep on doing it 10 to 15 minutes. So what happens, once the uterus gets contracted, again the uterus gets relaxed, again the uterus gets relaxed. Okay, to avoid that relaxation phase after the contraction phase, we do the uterine massage, and it has this thing has prevented a lot of BPH. So this is the last step, but it is not the least. Okay, so up to 15 to 20 minutes we keep on massaging the uterus, and this is how the manual placenta removal is done. Okay, this is how the manual removal of the placenta is done. Is it clear to you? Let us take the next topic, PPH. Please write down in the chat box if you have any query. Please write down in the chat box. Okay, what is PPH? What is the definition of the PPH? You all of you know one question is definitely going to come from this topic of PPH. PPH is the main cause of maternal death, students. Please, and it is only in the developing countries. Okay, we can stop these maternal deaths. Okay, so what is PPH? What is the definition? As we studied now only, that spiral arteries tear during the placenta separation, so some amount of blood loss is normal, but if this blood loss is more than 500 ml in normal delivery singleton pregnancy, then it is PPH. Some amount of blood loss is normal, and if this blood loss is more than 1 liter in cesarean or twins vaginal delivery, then it is PPH. Okay, the criteria of the PPH in the case of the normal delivery is more than 500 ml, and in the case of the cesarean it is more than 1 liter. Okay, as some amount of the blood loss is bit normal during placenta separation, the spike that we have discussed. Now what is the etiology of the PPH? Why the blood is pouring out? Okay, why the spiral arteries are not being contracted by the myometrium? So the most important and the most common reason is let me take the call. हेलो, मैं लाइव क्लास ले रही हूँ. हाँ, आधा घंटा. Okay, so here we were discussing there are four reasons of PPH. So I told you that you know that spiral arteries contract by the myometrial crisscross management, and okay, so crisscross fibers. Now, what if these fibers don't contract? Then there will be atonicity. Then there will be atonicity, and it will leads to PPH, and this is the most common reason of PPH, atonicity. Tone is affected. Rest three reasons: retained tissue, trauma, or thrombin. These are very less. Okay, these are very less. Okay, okay. What is primary PPH? Primary PPH is if PPH has occurred within the first 24 hours. This was a question of FMG June 22. What definition of secondary PPH was asked, and the secondary PPH is the PPH which is occurring after 24 hours up till 12 weeks. Okay, now let me tell you, there is a phenomena that once the uterus has contracted, again it gets relaxed, again it gets relaxed. Okay, that is why, and this occurs only up till first 24 hours, then this does not occur. So the reason of the primary PPH is atonicity. Okay, then after 24 hours, this procedure does not this thing does not happen, that uterus contract relax, uterus contract relax. Okay, so that is why the atonicity is not the cause of the PPH in the secondary PPH. Okay, atonicity is not the cause of secondary PPH. Okay, once the tone is there for 24 hours, then the uterus is not going to relax. Okay, do you got it? Okay, now as most common cause of the PPH is only atonic PPH, so we are going to discuss it only that. Okay, because what is in the other cause? Tissues, retained tissue, retained placenta, we have to remove it by DNC. It is so simple, right? Trauma, we have to, if there is any lacerations, we have to stitch that laceration. If there is thrombin deficiency leading to DIC, then we have to, what we have to do? Then we have to give the plasma or fibrin or the clotting factors. That's it. Okay, rest everything is easy, but atonic PPH is the one which is most common and which is responsible for the mother death. Okay, so now we will discuss atonic PPH. Yes, Dr. Isaac, the most common cause of secondary PPH is retained placenta or retained placental bits or retained membranes. It can be anything, even if a small part is left, that can also lead to secondary PPH. Okay, is it okay? Okay, so now we have learned that in the atonicity not occur after 24 hours, and that is why PPH is divided into primary PPH and secondary PPH. Okay, so atonic PPH, what are the risk factors in which we obstetrician we get very alert that yes, this risk factor is present, it means chances of PPH are there, and then after delivery 24 hours we are in stress. Okay, so the risk factor is over distended uterus. Okay, over distended uterus. Dr. Isra, in what relevance you are writing choriocarcinoma? Please write down as a cause of secondary PPH. Dr. Isra, you are writing as a cause of secondary PPH. Okay, now atonic PPH is due to risk factors. They have asked you a lot of questions on this risk factors because it's just three factors, and you should know in which patients the PPH is expected. Okay, so that we can prepare ourselves with blood and uterotonics and everything we can prepare. Okay, okay, so what is yes, it is one of the rare cause of the secondary PPH. Choriocarcinoma is one of the rare cause of secondary PPH. Okay, risk factor is over distended uterus. Okay, if the uterus is over distended, can you write down in the chat box when is a uterus over distended? When is the uterus over distended? Can you write down in the chat box? Over distended uterus is seen in the uh, twins pregnancy, because uterus get distended a lot, in macrosomia, okay, in polyhydramnios. So yes, Dr. Isaac, you are right. In the multifetal pregnancy, in the polyhydramnios, in the macrosomia, in all these conditions, even in the multiparous lady, okay, because there is prolonged distension of the uterus, so there is over distended uterus, right? And prolonged labor. In the case of prolonged labor, there is saturation of the, yes, in RH isoimmunization there is polyhydramnios, so there is it. Yes, in the diabetic mother too there is over distended due to polyhydramnios. Okay, so the management, yes, we were talking about the risk factors in the prolonged labor. In the case of prolonged labor, why there is PPH? Because in the case of the prolonged labor, there is saturation of the oxytocin receptor, okay, so it leads to prolonged labor. Okay, then there are infections, and because infections always they change the physiology, and it leads to non contraction of the muscles. Okay, so if there is a prolonged rupture of membrane, can you tell me what has happened to Shahjahan's wife? Mumtaz, yes, Mumtaz also died of PPH itself. Okay, now let us study the PPH management. When PPH occurs, we first of all the mnemonic is hemo. The mnemonic is hemo. So how we are going to deal with this hemo? Oh, let me tell you. H stands for help. We are going to call for help. Okay. Then A stands for we are going to assess the vitals. Okay. Sometimes the blood loss is too much and sometimes it is less. So we are going to assess the vitals and going to assess the real situations. Okay, we cannot just by seeing we cannot say the blood loss is moderate or severe. Okay, we assess the vitals and we come to the situation. And E stand for establish the etiology. As we studied that there are four etiologies: uh, tone, tissue, trauma, thrombin. So how we will establish the etiology? Just by doing by putting a simple one hand on the per abdomen. If the uterus is contracted, it means the causes are the other three. Okay, we're just going to put the hand on the uterus. If we are feeling the uterus is very tight, ball like, so it means that it is not, the tone is not the cause, uterus has been contracted. Okay, you have to just differentiate whether it is atonic PPH or whether it is retained placenta. Okay, retained placental bits. Okay, just by putting one hand, this step is very important. And 2015 question has been asked on this. What is your first management? How you establish the etiology? Okay, then HAEs establish the etiology. As usually the etiology is atonic PPH, so we are going to do its management. First step, once atonic PPH is diagnosed, the first step is do the massage. Okay, do the massage by manual compression of the uterus so that the uterus gets contracted. Now we know that the main problem is that uterus is not getting contracted. Now we will give the therapeutic uterotonics. First what we had given was prophylactic uterotonics. Now we will give therapeutic uterotonics. Just remember their doses. first drug of choice is oxytocin, and 20 units we give IV infusion. Okay, first we have given 10 unit. Then methergin is a drug of choice. Next drug to be given is methergin. The as you have to learn the emergency contraception doses, in the similar way you have to learn this pph doses. Okay, the methergin dose which you have to give is 200 mics injection. Okay, maximum 1 mg we can give, that is 5 injection we can give at a gap of half an hour. Carboprost dose is 250 mics, and carboprost has to given only and only IM, and maximum dose of carboprost has once been asked in exam, it is 2 mg, that is 8 injections we can give after gap of 10 to 15 minutes. Mesoprost dose, next prostaglandin which we have to use is mesoprost, and its dose is 800 mics. The route is per rectal or sublingual. Okay, what are the contraindications of methergin? We have already studied. The contraindications of methergin are heart diseases to the mother, hypertension, and Rh negative. The contraindication of oxytocin is that we have not to give it IV bolus because it leads to hypotension. And then carboprost, prostaglandin F2 alpha leads to asthma if given IV. Sorry, it is contraindicated in asthma patient, and if it is given IV, then it leads to severe bronchospasm, and sometimes it can lead to death also. Okay, prostaglandin F2 alpha, that is carboprost, is contraindicated in asthma patient. Okay, questions have been asked on methergin, questions have been asked on oxytocin IV bolus, a question can be asked on prostaglandin F2 alpha. Okay, now this is one slide on prostaglandin and its use. They confuse you, so I have put in on one slide itself. Prostaglandin E1 is name is mesoprost. Okay, and it acts on uterus and cervix both. How you will remember that it will act on uterus and cervix both? It is very simple. It is the first. It is on the top, and its name is meso, main drug. It is acting on both uterus and cervix, so it can be used to induce abortion. Okay, in the second trimester, prostaglandins are the drug of choice. In the first trimester also we give it along with mesoprost. They are used in abortion induction, and they are used in labor induction because it is acting on cervix. When we have to give it in abortion and in the labor induction, there we have to do cervical ripening. So, and as we have seen that it can also be used in PPH also, because when we have to contract the uterus, then we want the drug to act on the uterus. Okay, so prostaglandin E2, the medical name of it is dinoprostone. It acts only on the cervix, so that is why it is used only in abortion induction and labor induction. Okay, prostaglandin F2 alpha, carboprost, it acts only on the uterus. Therefore, it is not used in abortion and labor induction. It is only used in PPH. So they keep on asking that which prostaglandin is not used for labor induction, which prostaglandin is not used for abortion induction, which prostaglandin is not used in PPH. So dinoprostone is not used in PPH. Is it clear to you? Okay. Now, once we have given all the uterotonics, still the bleeding is not getting controlled. So now we have to give tamponade. That is, we have to put pressure, and we put it by Bakri balloon. Okay, and we put it by inflating the Bakri balloon in the uterus. Then that inflated Bakri balloon gives the pressure on the myometrium, so that myometrium can get contract. Okay, the and this we are going to do in OT. Okay, the second method procedure which we are going to do in OT, if the tamponade also fails, is compression suture. That is a B-Lynch. All of you know this. Okay, All of you know this compression sutures, Beeling sutures, you all do write in the quiz. Okay, so I haven't discussed here in detail. Next is the devascularization procedure. Now we have seen that myometrium is not getting contracted. It is not even getting contracted by uterotonics. It is not even contracted by the Bakri balloon. It is not even contracted by the Beelinch sutures. Okay. Now what we are going to do is, now we are going to ligate the arteries which are supplying the uterus. Okay, so that the blood pressure with which the blood is flowing, it gets decreased and our pph gets slows down or stops. Okay, so first of all, the artery, this because if and here the we do ligate it very loose, because if we will tightly ligate, then the blood supply will be obstructed and the part will get into necrosis. Okay, so we give a ligation, but it is a very loose ligation. Okay, the uterine artery is first of all ligated. As you all know, uterus is supplied mainly by uterine artery. Then the second artery, if still the bleeding does not stop, is the ovarian artery. Okay, and still if the bleeding continues, is the anterior division of the internal iliac artery. Okay, anterior division of the internal iliac artery. Okay, next what we do is we undergo embolization. Okay, we stop the blood flow by embolizing the arteries. So we undergo uterine artery embolization, and at last we undergo hysterectomy. Is it clear to you? So the first thing which we are going to do in the OT is tamponade, then Beeling sutures, and at the last we are going to, in the last two procedures, we are going to play with arteries. First we are going to devascularize it, and the last we are going to embolize the arteries. Now here are the branches of internal iliac artery. This is very, very, very important. Why this is asked so much times? Because when pph is occurring, as you have seen that devascularization is our last hope, and there we as a obstetrician, we get confused a lot. Okay, which artery to ligate, what to do, so that you don't get confused when you're saving one life. That is why this question is asked too much. As you all know, pph is the main cause of maternal death, right? So internal iliac artery branches are asked. It is very important. Last November exam it has been asked 3-4 times in the FMG. It has been asked multiple times in the NEET PG. So it is very important. Even your exam, August 20 exam, that horrible exam, even in that it was asked. So it is a pet question. This slide से question आना ही आना है, ठीक है? Internal iliac artery has two branches, anterior branch and a posterior branch. Anterior branch gives out 8 branches, sub branches, and posterior division gives out 3 branches, which are learned by the mnemonic short gills. Okay, let's first learn the posterior division branches. Okay, posterior division, one division is in the posterior division, SG stand for superior gluteal. Okay, and IL stands for iliolumbar, and LS stands for lateral sacral. Is it clear to you? So these are the branches of the posterior division. Okay, in the anterior division, you know that uterine artery is a branch of the anterior division. So simple question was asked in August 20, when we ligate anterior division of internal iliac artery. So the answer was pph. Okay, so the answer was pph. When we ligate anterior division of internal iliac artery, so the answer was pph. Okay, so what are the branches and how to remember? Posterior division branches we remembered with the mnemonic short gills. How we are going to remember the anterior division branches? We are going to remember it by we know one fact, we know very clearly, and that fact is that bladder is in anterior, uterus is in the mid, and rectum is in the posterior. Okay, bladder is anterior, so two branches to bladder. Okay, superior and inferior vesicle, next branch to the uterus, and one branch to the rectum, middle rectal. So these four branches should be very clear to you, because you know that bladder is in the anterior, and uterus is in the middle, and in the last it is rectum. Okay, so ठीक है, superior vesicle, inferior vesicle, uterine artery, and middle rectal artery. Is it okay? Is it okay? Okay, now the other four branches, how you are going to remember it? Now you know that thigh is anteriorly, then comes the vagina, then comes the gluteal region. Okay, so obturator, then pudendal and vaginal, and then inferior gluteal. Okay, so just you are going to remember what is there anterior to posterior: bladder, uterus, rectum. So are the branches: superior vesicle, inferior vesicle, uterine, and middle rectal. Then what is there? Then thigh is there. To the thigh the branch goes obturator artery. Then vagina is there and perineum is there. Then the arteries are pudendal and vaginal, and then in the last is inferior gluteal. Okay, now in the questions, how they, thank you Dr. Isaac, thank you Dr. Isra, you like my mnemonic. Now in the exam, how they confuse between superior inferior vesicle and superior inferior gluteal. Please, when you are studying this topic, please clear the superior inferior vesicle and superior inferior gluteal, because this is the point in the exam where we get confused and where the examiner confuses us. Okay, is it clear to you? Okay, now let us see the secondary PPH. Secondary PPH is the PPH which is occurring after 24 hours, and it gets and it is up to 12 weeks. Okay, and it is the PPH, it can occur up to 12 weeks. Okay, it has seen that small placental bit can bleed up till 12 weeks postpartum. Okay, first it was up till 6 weeks, but now they have done it up till 12 weeks. Okay, most common cause is retained placenta, placental bits or membranes. How you are going to diagnose it? Superior gluteal is absent. No, Dr. Kavita, superior gluteal is in the posterior division branch. Got it, Dr. Kavita? You can see that superior gluteal is in the posterior division branch. Short gills. Okay? Okay. Secondary PPH is the PPH which is occurring after 24 hours. Hours and up till 12 weeks. Okay, then most common is the retained placenta. Cause is that, and it's diagnosed by there is subinvolution of the uterus. There is subinvolution of the uterus. Uterus height, fundus decreases in size as the postpartum period progresses, but there will, because the membrane has been left inside or placenta has been left inside, so there is sub involution of the uterus. So if they say that on day 5 also the uterus is 20 weeks, inferior rectal is not there. Inferior rectal is not the branch of internal iliac artery. Okay, only middle rectal is the branch. I have to see anatomy book to see whose branch is inferior rectal. Okay. Okay, so yeah, Dr. Kavita, you are right. Yeah, it's you are right. In the interior division, it is absent. Yeah, you're right. Okay. So most common in the retained yeah, how we diagnose in the postpartum period that membranes are left, small bleeding occur. It's not a major bleeding, that is why we don't fear from the secondary pph. Small bleedings, spotting, or just mild bleeding occurs in secondary pph. That is, we don't get fear from that. Okay. So diagnosis is by subanvolution, fundal height it keeps on increasing, and there is mild sepsis. Okay. How we are going to treat it? We are going to do DNC. Even after DNC, if the bleeding is present, then it means it is a persistent trophoblastic